Today I have a little respiratory talk for you. Hopefully the audience that's listening finds some valuable information. I have nothing to disclose. You can see our objectives listed here. We'll open up our talk starting from the beginning, talking about lung physiology. I have a nice little diagram for you here. I would never want anyone to memorize the different stages of lung development. I just want to really focus on the canalcular stage, which is from 17 to 27 weeks. And that's where we start to really emerge into a functional lung. And at this stage, we have the channels starting to evolve into air spaces and alveolar formation. And not only that, getting the capillaries to surround the air spaces, which becomes really important in gas exchange. We also have a differentiation of type 1 and type 2 cells in the lung. And we're going to talk a little bit about type 1 and type 2 cells and how they're different and why they're important. And here we have an alveoli taking a look at our type 1 and type 2 cells. Our type 1 cells, just by looking at it, you can tell that that has a really important function of being a gas exchange surface. And our type 2 cells, those are the caretaker cells. They respond to damage, they make sure to fix things up, keep things running, and they are also super important in secreting surfactant. And this is a pretty basic slide actually, and we take normal lung mechanics for granted. I think we just do our breathing and we just go about our day, but there actually is different components to lung mechanics that really keep things working efficiently. And the definitions that I have listed on this slide are more for you to be familiar with because they will become important when understanding respiratory support. And knowing these and being familiar with these is going to help with that understanding. Okay, with this slide, I really want you to appreciate this diagram, okay? I want you to take a look at and really appreciate this close connection that the capillaries have with the alveoli, and understand that if there is something going on with the blood flow or the inflation of the alveoli, respiratory status can be affected. And when we talk about ventilation and perfusion, this is what we're talking about. If we have something going on with our blood flow, we can't have gas exchange happen in a normal way. If we're not inflating our alveoli, that's going to affect our gas exchange in a different way. So when we talk about ventilation, the alveoli getting air in, or perfusion, the blood flow that comes in contact with our alveoli, it can help us better understand respiratory status and help our baby a little bit better. Okay, here we go. Another slide on ventilation and perfusion. This one looks at it a little bit differently. And what we have here on this side, poorly ventilated alveolus, it can be due to surfactant deficiency, where we can't inflate our alveoli, meconium plug, blocking the way for air to get in. So this ventilation is affected. Can't get air in, means that we can't have good gas exchange. You can have blood flow all day long, all night long, it doesn't matter. If you are not adequately ventilated in this situation, you're going to have a baby with respiratory distress. On the same token, look at here, we have inflated alveoli, can get the air in no problem. But if we don't have adequate blood flow, then we can't exchange CO2 for oxygen. It's just not going to happen. So respiratory distress or poor oxygenation happens for two different reasons. And understanding this will help you understand why different methods of respiratory support help baby in a different way. Okay, why do I have a slide on extrauterine transition in here, right? I want you to think about extrauterine transition from a perspective of ventilation and perfusion. So what's important to understand in this slide? In utero, we don't need our lungs, right? The pressures in the lungs are high. The vasculature is tight, and that is a perfusion issue, right? We don't have good blood flow. We don't need our lungs. Not only that, there would be a ventilation issue because our alveoli are fluid filled. Fluid filled lungs, baby doesn't need to, the lungs don't contribute to gas exchange as a fetus. So the lungs are considered a high resistance circuit, and the pulmonary pressures are considered high. Once the baby's born, a whole bunch of things have to happen correctly in order for the babies to resume or start off a normal respiratory status. Okay, here we go. Once the baby's born, now this is when things go normally, okay? Infant comes out, infant takes a breath. We know that oxygen is a potent vasodilator that opens up the blood flow, right? This is perfusion. Now we've got good perfusion coming in, and that baby takes a breath, so fluid gets pushed out of the lungs, and now we have ventilation, and the alveoli are opened up, so now we have good perfusion and ventilation, and now our lungs can function normally with gas exchange. At this point, in order for that to happen, when the lungs open up, the pulmonary resistance drops. It's only when that pulmonary resistance drops that we can have that good blood flow coming in. And because of that low resistance, the lungs are encouraged to take over the work of gas exchange. And if it doesn't happen, this can cause a VQ, or ventilation and perfusion mismatch, being the contributing factor of respiratory distress. Okay, so how do we know baby has respiratory distress? What might we see? Well, probably see some grunting, flaring, retracting. Take our stethoscope, take a little listen. Got good air movement, poor air movement, fair air movement. Chest x-ray might help us. Blood gas, that might help us. But let's also think of a few more things. So for things to go normally, we need a little help. We need a little signal for the lungs to get ready. How does that happen? Well, mom's going through labor. We have a release of certain hormones. Those hormones help decrease the amount of fluid that is in the lungs. In my reading, there's actually a study that I came across, and it was a study using fetal lambs. And in this particular study, the lung liquid were reduced from 21 mLs per kilo at the beginning of labor to 6 mLs per kilo at the time of delivery. And that was pretty remarkable to me, that labor contributed to the drop in fluid within the alveoli that extensively. Another thing that happens is a small portion of fluid is removed through the squeeze through the vaginal canal. We know that we don't get that same quality squeeze from a C-section. And then we get additional fluid pushed out with the first loud cry after birth. But sometimes things don't happen that way. What happens if you have a scheduled C-section? Means you don't have labor, means that you don't get that additional little squeeze from the vaginal canal. Moms who have gestational diabetes, their lungs don't mature as quickly, So we have a delayed lung maturity in those babies. What happens if the baby doesn't let out a good initial first cry? Prematurity, surfactant deficiency. We don't have our adequate amount of surfactant in our lungs. And then there's factors that don't even seem related that can affect respiratory status. Like if a baby is too hot, they become tachypnic. Babies with low glucose, babies that are hypothermic that get rewarmed too fast can become apneic. So sometimes there are factors that don't even seem related. Don't forget that babies are obligate nose breathers, so even a small amount of secretions in their nose can affect their ability to breathe. Some babies have choanal atresia where they have a blockage that when they cry, they're nice and pink, but when they're quiet and breathe through their nose again, they turn dusky. We have babies that can have a little laryngomalacia or floppy airway that might affect their respiratory status. So there really are multiple things, and it's up to us to know what we're looking for, go through our mental checklist to help these babies out. This little diagram just visually putting out what I just mentioned and looking at respiratory distress being related to different causes, respiratory, non-respiratory. And if respiratory, are they lung related or related to things that aren't quite the lungs? So now we're mainly going to focus on these things right here as we continue in our talk. Okay, first on our list, TTN, transient tachypnea in the newborn. It is just a delayed clearance or excessive amount of fetal lung fluid. Typically happens in near-term or term babies. These babies are sometimes delivered quickly, and anything that can interfere with a delay in that fluid getting pushed out can contribute a baby to having TTN. These babies are the babies that are breathing what seems to be a million times a minute, 80 to 100, sometimes 110 breaths a minute. They have mild to moderate retractions, maybe some grunting, flaring. These babies can start off grunting and breathing at a pretty normal rate and then transition to quiet breathing but tachypnic. And when you take a listen to them, these babies actually have good air exchange. Initially, the breath sounds, they may be a little coarse, but as time goes on, they actually do have air entry. There are times that I listen to these babies and I'm like, hey baby, just so you know, you've got great air movement. You can stop with this business now and get over yourself. But these babies can take from a couple hours to 3, sometimes 5 days to transition out of it. These babies have minimal cyanosis, don't really require a lot of oxygen. And like I mentioned, they're term or near-term babies, and we just got to help them through. We just support them based on symptoms. CPAP is really common. It can open up those alveoli, help push some remaining fluid away. Sometimes babies just need a little cannula. We just have to go based on the baby. Okay, here we have a X-ray that's pretty classic for TTN. A few things to point out in this X-ray is one, that it's actually a really good X-ray. We have the clavicles that are symmetrical. Each side of the lungs looks symmetrical. One side doesn't look longer than the other. And then for TTN, it's often described as a starburst pattern. Some of this is vasculature, but some of it is fluid. And you can see these offshoots, the heart kind of being the center of a sun, and then we have these offshoots here. This arrow here is pointing to fluid in the fissure, which isn't super common, but you can see it. And another thing when we're looking at x-rays is we look at lung volume, and we do that by counting the ribs. 1, 2, 3, 4, 5, 6, 7, 8, a little bit. Now, ideal lung inflation is about 9 ribs, so we could say that in this particular x-ray, this baby is underexpanded. Okay, and probably even more common than TTN is RDS, respiratory distress syndrome. It is respiratory problems related to surfactant deficiency. And the lower the gestation, the higher the chance of RDS. That surfactant hasn't had a chance to fully be produced. And it is the most common cause of respiratory failure in the preterm infant. So RDS, surfactant deficiency. And when you have surfactant deficiency, that comes with other problems. Those alveoli can't open up. You can't get good oxygen in, and those lungs can't open up properly. Our preterm infants, depending on how early they are, think about that first diagram. Think about where in that lung development could they be, and how functional do you think their lungs are? We have a few risk factors. Again, prematurity. A second twin related to the predisposition to some depression at birth, not quite getting quality oxygenation, which contributes to poor oxygen exchange. We also have, again, infants of a diabetic mother, delayed lung maturity, and commonly what we'll see is that males tend to do a little bit worse than the females do. Now, before I talk to physical exam, one thing I did forget to mention is antenatal steroids, game changer. Those steroids that those moms get prior to the delivery of their preterm baby, those steroids kind of speed up lung maturity a little bit. Hopefully, if the baby does have RDS, probably doesn't have it quite as bad thanks to those mothers taking those steroids. But on physical exam, babies with RDS have tachypnea, they have grunting, flaring, retractions, and they're a little pale, a little cyanotic, need some oxygen. And when you listen to them with that stethoscope, they have diminished breath sounds because that air isn't getting in as nicely as we want it to. And this is kind of a redundant slide, but again, just mentioning increasing amount of respiratory difficulty, diminished breath sounds, and increasing oxygen requirements. We might find some helpful information in a blood gas. On the blood gas, we might see that the baby has a little bit of a hypoxemia, high CO2, because they can't have good gas exchange, be a little acidotic, and depending on if they were without oxygen at birth, they may become a little bit metabolically acidotic as well. And then we can get a chest x-ray. That can give us some valuable information. And these babies can have small volume of lungs, are underinflated. We can see some air bronchograms and a ground glass appearance. And we're going to take a look at that now. Okay, so here we go. Here's an x-ray of RDS. How do I know? Well, the most remarkable thing is what we call this ground glass pattern. See how it looks really dotty? And that's because there are some alveoli inflated and some not inflated. The ones that are not inflated appear white, and the ones that are inflated seem a little bit more black. And then along with that, we can see air bronchograms. See right here, you can see these tubes right there. Those are air bronchograms, and we can see them all so well because the background is so atelectatic, creating a white background on these air-filled bronchi that make them stand out more. And then we can take a look at lung inflation. Counting our ribs again, 1, 2, 3, 4, 5, 6, 7, 8, 9. This baby is actually adequately inflated, but you see this haze of white kind of whited out, kind of like this blanket of white. We can barely even make out our heart borders. That's how collapsed these lungs are. And here's another one, that blanket of white again, that whited out appearance, barely seeing our heart borders. Here we have some air bronchograms here. And you can see that really dotty or reticular granular appearance of those lungs. This baby just happens to be underinflated. 1, 2, 3, 4, 5, 6, 7, 8, and a little bit on this side. So this is typical for RDS. So based on our information, what are we going to do? Well, our therapy is aimed at maintaining oxygenation, adequate ventilation, going back to ventilation and perfusion, and we want the goal of a normal pH, and with adequate oxygenation becomes adequate perfusion and tissue oxygenation. Those are our goals for this baby. And if we've got to give some ventilatory support, then that's what we've got to do. But primarily what these babies need is the administration of surfactant. So I have a little video for you here that I want you to take a look at. Now this baby obviously is in respiratory distress. We see a few things in this video. We see some retractions here. We can hear this soft grunting. Can't quite make out if there's some nasal flaring here or not. But this baby looks pretty big, right? This baby probably is close to term or is term. And that baby, if we got an x-ray, based on those few things that we see in that video, that baby probably has some TTN. Okay, I have another video for you here. You can hear the grunting. Yeah, we have some grunting here. So this baby, and I don't know if you can see that, but the pulse ox is reading 98%. And he just mentioned that this baby was a C-section delivery. Now this baby does look a little small, maybe late preterm baby. Okay, so for this baby here, could be a combination of a little surfactant deficiency and TTN, but the baby does look to be a late preterm baby just because of its size. So, and as he mentioned in the video, was a C-section. So we could very possibly have a little bit of retained lung fluid and have a little bit of surfactant deficiency. We did see that the baby's SATs were 98% on room air, although he kind of had an oxy hood on him. So without a few additional tests, we don't know for certain, but my guess is that it's probably a combination of the two. Okay, here we go. We got a question. A feature that distinguishes TTN from RDS is A, TTN requires mechanical ventilation, B, TTN patients have virtually clear x-rays, or C, infants with TTN tend to have a normal or low PCO2. And I'll give you a second to think about that. And for this particular question, the answer is C. We took a look at a TTN x-ray. I think if you look back, or you can go back on the slides, that babies with TTN do not have a clear x-ray. They have that starburst pattern on their x-ray. And we also talked about the fact that these babies don't typically need very much. C is the correct answer because these babies are breathing typically tachypnic, so they're blowing off a lot of their CO2, so they tend to have a low PCO2 or normal. So hopefully you got that question correct. So now it's time to talk a little more extensively about surfactant. Okay, we have these circles here that are representing alveoli, one without surfactant and one with surfactant. And with the one with surfactant, we can notice these squiggly lines, which are representing these lipophilic tails on the outer layer, and that is forming a barrier, and they are kind of pushing against each other. They are hydrophilic. They don't want to touch. So they are pushing away from each other, essentially opening up that alveoli. When you don't have surfactant, you just have this water layer, they are attracted to each other, designated by these arrows, just pulling in and contributing to collapse. Here we have another picture of an alveoli with a surfactant layer. You can see type 1 cells. Remember, we talked about type 1 cells being responsible for gas exchange. And we have our type 2 cell here that spits out surfactant within the wall of the alveoli. So essentially what surfactant does is decreases the surface tension over the alveoli, and optimal surface production is not complete until 34 to 36 weeks. Now the nice thing about surfactant is our bodies can recycle it even when we give it artificially. The body can reuse those substances to make more surfactant. And another little diagram for you, just taking a look at prematurity and showing our different issues of inadequate surfactant in a structurally immature lung. And here we go, thinking about it as a VQ or ventilation perfusion mismatch. Inadequate surfactant leads to collapsed alveoli. We have a ventilation problem. And depending on how immature our baby is and how well formed their lungs are, what kind of capillary network do we have surrounding the alveoli? So there can be an issue with that as well. When you have a VQ mismatch, it leads to hypoxemia and hypercarbia, and those cause its own fleet of events. The more support we have to give a baby, the more oxygen, baro, or volume trauma we cause, and that can really contribute to a heightened inflammatory response, which contributes to bronchopulmonary dysplasia, or chronic lung disease. And we take a look at our blood gases, if they're respiratory and metabolically acidotic. That can lead to pulmonary vasoconstriction, further lung tissue injury, and essentially continue with this cascade of respiratory distress. So what do we know for sure about surfactant? Quite a bit, actually. We know that surfactant is an effective treatment for RDS. We know that surfactant decreases surface tension with the alveoli, allowing for ventilation. And if we can achieve this, this means that we give less respiratory help, less of a chance to cause trauma to those lungs. Surfactant, once the alveoli open up, it's going to improve our gas exchange and oxygenation. And with that, makes sense that if we can turn things around, we're going to show decreased risk of chronic lung disease, decreased lung injury, decreased mortality, and less acute pulmonary injury. When we do not have enough surfactant, this just represents the cascade of events that follow because of that. When you don't have surfactant, you have alveolar collapse, you have poor lung compliance, which leads to decreased air exchange, increased pulmonary resistance. We've heard that term before earlier in the talk. Decreased oxygenation, increased work of breathing, respiratory failure, and death. What's our responsibility as a nurse? Well, we want to take great care of this baby. So before we even give our surfactant, we want our emergency equipment ready. We want a neopuff in the room. We want our suction ready to go. And that includes a 8 or 10 French size catheter because during intubation, you want to be able to assist the provider in intubating, and sometimes that includes needing suction. So you want to have that readily available. We also need to know an accurate weight of our baby so we can determine the right size ET tube. And the way I remember, I keep it easy, 1, 2, 3. 1 to 2 kilos gets a 3.0 tube. If you are above 2 kilos, you get 3.5. If you're below 1,000, you get 2.5. I have very rarely used a 4.0 tube. I can count on one hand in almost 30 years. You also need to do a timeout prior to procedure and give support to your baby. If you can keep them a little bit swaddled, you want to keep their chest open so you can watch for chest excursion. And as you're giving the surfactant, you're going to have a rapid change in lung compliance. And sometimes that means adjusting the size of the breast that you're giving with the neopuff, maybe dropping the PIP a little bit, dropping your FiO2. So it is a team effort and everybody needs to be paying attention. Typically, I am used to giving surfactant in 2 aliquots, half on one side, turning the baby to the left side, half turning the baby to the right side. There are some NICUs that give the surfactant flat. The research doesn't support one way or the other, so this is a provider preference. Okay, I have a question for you. If you hear faint breath sounds on the left side and normal to slightly louder on the right side, immediately after you intubated your patient, what is most likely the cause? Most likely, A, right main stem has been intubated, B, the physician has intubated the esophagus, or C, a left-sided pneumothorax. So the answer for it to most likely be is A, the right main stem. If you look at normal anatomy of the lung, it is very easy for the ET tube, when pushed in too far, to go down the right main stem. So our breath sounds are going to be a little bit louder on the right. So once your patient is intubated, You grab that stethoscope and you take a listen while the respiratory therapist is giving some breaths. And if you hear louder on the right, you let your team members know. Someone will pull that ET tube back a little bit. You take another listen, making sure your breath sounds sound equal. And that way, that is one of the signs to help you know that you're in a good location. Now, if the provider intubated into the esophagus, you would hear breath sounds over the stomach. And vital sign wise, your patient probably isn't going to be doing that great because the ET tube is not where it's supposed to be. I guess you could have a left-sided pneumothorax, but that's not most likely. You're at higher risk to have a pneumothorax after you give the surfactant just because of the compliance change. So I have another video for you here. This one is intubation and surfactant administration, and hopefully I can kind of give a few comments as this video goes on. It's going to take a little bit here. I'm sorry, I'm not savvy enough to be able to fast forward this video. Now, prophylactic and treatment is giving surfactant at the delivery room, and usually it is better to assess your baby and see how they're doing first. Only if your baby is really not doing well at delivery do you give surfactant. Now they're intubating this baby. Part of your responsibility is to tell the provider to not do what this provider is doing in this video. He is rocking back the laryngoscope, denting into the baby's upper gum line. When you intubate, the laryngoscope is a pull down motion, not a rock back motion, and that's important feedback to give to the provider. So here he's intubating his baby. He's going to take out the stylet, and now they're bagging the baby. At this point, someone should be listening for equal breath sounds, and there should have been a PD cap on the end of that noting a color change from purple to yellow. Here they're bagging that baby, and that actually causes more volume trauma because the pressures are very variable. When you're giving PPV breaths with a T-piece resuscitator, the PIP and the PEEP are set, so the breaths that you are delivering are very consistent. You can see that they put on the surfactant adapter there, and they are positioning their baby to its right side, getting ready to do the first aliquot or give the first half of the surfactant. They're going to take that catheter and they are going to match up the measurements from the ET tube and deliver that catheter right to the tip of the endotracheal tube when they push in the surfactant. So they just said that they were bagging 25/5, which I would be super careful about when you're giving surfactant because the compliance changes. So they're inserting the catheter, and the goal is to have that tip be at the tip of the endotracheal tube. And she is pushing in the surfactant, slow and steady. Sometimes you'll see surfactant come up in the endotracheal tube, and you might have to give it a little bit slower, but they're bagging the surfactant in. And you wait about a minute before you turn the baby to the other side. So they're giving the baby a little bit of time, and now they've turned to the other side and they're giving the second aliquot of surfactant. Okay, they're pushing in the catheter once again, getting to the tip of the endotracheal tube. Okay, she matched up her numbers, maybe. There we go. Given our second dose of surfactant, our second aliquot. She's going to pull the catheter out. Okay, I'm bagging that in. Wait a minute. And during this time, they might want to bag with a little bit less pressure related to the compliance change. If they're on oxygen, they need to be watching the oxygen and weaning the oxygen down, because if the baby's responding well to surfactant, you're going to see those changes right away. You really have to pay attention. Okay. Okay, here's another video on surfactant administration. And I do not want to be redundant in playing it, but if you are interested, you can go to this NICU trainee portal. You can see the YouTube code for this video right at the bottom here. And if you're interested in watching the video, you can go to that video, but that is a good resource. So in that previous video, if you move further into the presentation, it gives you a little bit more detail on surfactant administration if you're interested to watch that. Now, when they were intubating, one of the things I mentioned is that we didn't have the opportunity to see them use a pedicap or a CO2 detector, which there's a few different kinds, but this is probably the most common one you'll see. There is also one called the Neostat, which is the only one approved for babies less than 1 kilo. But what happens is when you put this at the end of the endotracheal tube and you're giving breaths, the color changes from purple to yellow, and that lets you know that you've intubated into the lungs. Okay, let's talk about meconium. And this will give us a whole different set of problems and can contribute to respiratory distress. So let's talk about meconium in relation to ventilation and perfusion. You can see in this diagram here, normal functioning alveoli, good blood supply, nice and open, gas exchange, no problem. With a complete obstruction, you got a meconium plug right in here, can't get air in. So you got to have a ventilation problem. Doesn't matter that your blood flow is great. If you can't ventilate, you can't get good air exchange. With a partial obstruction, sometimes we can have what's called a ball valve effect, where air can get past the meconium plug, but can't escape out, and what that leads to is an over-distended alveoli. Along with the overinflation of alveoli, that can affect pulmonary circulation as well. And then in addition to an over-distended alveoli, look at here, you can have an over-distension and rupture. And guess what we're talking about next? Air leaks. Also, something about meconium is that meconium deactivates surfactant. Typically when the decision is made to give surfactant to help a baby out because of this inactivation, usually it ends up being 2 doses, because the first dose kind of is a wash, it kind of cancels it out. And then it's the second dose that we get some surfactant benefit. On the right, you can see an X-ray, totally different patterns than TTN and RDS, right? Here we have what they call diffuse bilateral dense infiltrates that are in the lung, and typically if they're air trapping, you're going to see an over expansion rather than an under expansion. If we count the lungs, 1, 2, 3, 4, 5, 6, 7, 8, 9, this is actually adequately expanded. Other things that you can look at on the chest x-ray that we haven't talked about yet is heart size. So if a heart size looks small, it can mean maybe dehydration, or if the lungs are overinflated and pressing on the heart can create it to look a little bit smaller. So as you can see, the chest x-ray really gives us some good information. Also, the endotracheal tube tip we can see right here. And then that is a low UAC and a low UVC, but that's for another day. So typically, if we're working in the NICU, we'll get called to a meconium delivery. Meconium in the fluid usually indicates a problem with the fetus. It happens due to stress caused by hypoxia or infection or placental dysfunction. And if the baby is stressed enough, gasps in utero, we can get that meconium inhaled into their lungs, and then when they come out and take that breath, it can move further into the lungs, plugging up those airways, so it can cause a mechanical obstruction. We already talked about surfactant inactivation. Also, that meconium is kind of caustic to the lungs and creates a pulmonary inflammation. And as we looked in that previous diagram, can cause pulmonary air leak. So let's talk about air leaks for a minute here. Pulmonary air leaks, uh, it can happen in healthy term infants. That first breath can generate huge pressures, and that alone can cause the alveoli to rupture and cause an air leak. There's also infants with pulmonary diseases if their lungs are non-compliant. And again, ball valve obstruction seen with meconium aspiration. And then always a risk, babies on CPAP, or if you're giving positive pressure ventilation, sometimes those pressures are too much and can cause an air leak. So typically it's iatrogenic. We cause it, resulting from an excessive use of pressure. Sometimes there's an uneven air distribution at birth where some alveoli are open and others remain collapsed. And as the baby, or even us as we're trying to help the baby generate pressures to expand those collapsed alveoli, they can create more pressure in the alveoli that are already expanded, causing those alveoli to rupture. Sometimes there's an underlying lung disease, again, talking about air trapping, and then there's poor lung compliance as seen with RDS. So I think the most common type of air leak we're familiar with is a pneumothorax. Now these babies, they can deteriorate very suddenly, or it can be subtle. I've had babies have a huge pneumo but actually tolerate it really well. And it really depends on your clinical assessment on keeping this in mind as a problem that your baby is having. So you can have your baby be having a great shift, everything looks fine, and then all of a sudden the SATs are horrible, not coming up with extra O's, where they were comfortably breathing before. Now all of a sudden they have retractions to the backbone. When you pick up your stethoscope, these babies have decreased breath sounds on the affected side, or the side that has the collapse. And then with that, now you've got air occupying the side, the lung is not expanded, and that pressure can push up against the heart and leaving the heart not to pump effectively, causing hypotension, affecting the baby's perfusion, causing skin mottling. And then with your assessment, instead of hearing louder heart sounds on the left, let's say, if you have a left-sided pneumothorax, that air pushes the heart over and your heart sounds might actually be louder on the right. Sometimes you can, in a pinch, take a transilluminator or a light and shine it on the chest. And when the transilluminator is placed up against the chest wall, it lights up like a Christmas tree bulb. But I've also done that too and haven't been able to really tell a difference. Really the best bet is to get a chest x-ray. But if your baby is deteriorating suddenly, you may want to have your provider needle the chest. Some babies actually have a small pneumothorax and be asymptomatic, and the only way you find it is by getting a chest x-ray for a different reason. These are a few other types of air leaks you might see. Pneumomediastinum is a collection of air in the mediastinum area. On auscultation, you might hear indistinct heart sounds because the air is occupying that space. A pneumopericardium is a collection of air around the heart, and this can be associated with hypotension, muffled heart sounds, and bradycardia. And this is life-threatening and very scary because that air surrounds the heart and prevents it from pumping effectively. There is also PIE, pulmonary interstitial emphysema, And this is a collection of air and gases outside the alveoli, where the air escapes from the alveoli and then enters the interstitial tissue nearby, damaging the lungs and causing PIE. And it can be either acute or chronic, localized or diffuse, and this can be a real challenge to manage. Typically, we see these in infants with really poor lung compliance and are on mechanical ventilation. And it can also progress to a pneumomediastinum or pneumothorax as the air leak progresses. Now, in physical exam, I talked a little bit about this already. You can see tachypnea, grunting, flaring, and retracting, any sort of signs of respiratory distress. These babies, you turn up their oxygen and their sats are still poor. And then their perfusion is affected. If it's a pneumopericardium, that air surrounding the heart kind of squishes the heart so it can't pump effectively, or if it's a pneumothorax, let's say, that air is pushing up against the heart, and again, the heart can't pump effectively, so that's going to affect your perfusion. These babies can be restless and irritable as their CO2 levels rise. The breath sounds in the effective side are going to be very poor, non-existent, and heart sounds can sound muffled because that air is now in the way, preventing you from hearing the heart sounds appropriately. And getting a chest x-ray is the best bet. I have this slide here just looking at chest x-ray findings, but the next slide I actually have a few x-rays that we'll take a look at. Okay, we have a few x-rays here. On our first x-ray on the left, we can see pneumopericardium, and you can actually see this rim of air encircling the heart. So it's kind of easy to understand why this air puts pressure on the heart and affects its ability to pump effectively. The middle x-ray we actually did not really talk about. It's a pneumoperitoneum, and this happens when air dissects down from the mediastinum through the sheaths of the great vessels to have an air leak within the abdominal cavity. And then the x-ray on the right for pulmonary interstitial emphysema. And it really does occur primarily with babies who have RDS and who are on mechanical ventilation. And the mechanical ventilation that the babies are on, you know, we have to give enough pressure for what they need to keep the alveoli open, but it can also cause the alveoli duct to rupture. And that's what leads to the escape of air in the pulmonary interstitium. And this is an x-ray of a pneumothorax. You can see this rim of air. And you can see that our heart is more pushed over to the left, since this is a right-sided pneumothorax. So what do we do for these x-rays? Well, a pneumomediastinum, usually you don't do anything. The air kind of resolves on its own. The pneumopericardium is an emergency treatment, and that requires the placement of a long catheter into the pericardial sac with constant negative pressure. PIE can really be a challenge to manage. The ventilatory strategies that you need to manage PIE are reducing the inspiratory time and or decreasing the pressure. So it's a challenge to give enough pressure to keep the alveoli open and not cause a worse air leak. So what do we do for these babies that have a pneumothorax? Well, we can do a needle thoracentesis, and the nice thing about that is that it's a really fast way to remove air, especially in a compromised infant. Uses a butterfly or an angiocath stopcock and a syringe. And if your infant is at risk for a tension pneumothorax, there's no reason why you can't just keep a chest needling kit at the bedside. Um, the baby needs to be monitored throughout, and if they have a needle thoracentesis done, about 30% of babies do not need a chest tube. And here's the setup that would be used. You have your butterfly, your stopcock, and then your syringe for pulling out the air. And I have a little video for you that is running a little bit higher speed because it was just taking forever. And this is just so you have a visual on what this procedure looks like. And it's a pretty common procedure or done first before a chest tube is placed. And like this slide is mentioning, it's a nice way to evacuate air, especially in emergency. So in this particular situation, it's a term baby with RDS on CPAP who was desaturating, and even on 100% O's, you can't get these sats up. And you can see this baby is having a tough time, really working to breathe. And when they listen on auscultation, the air entry is reduced on the right side. And here they use a transilluminator, and you can see that it is really bright on that side. And the team agrees that a needle thoracentesis should be done. And of course, that procedure is done by a provider. And it's a team effort, so typically 2 nurses, one to help for the procedure and one to help monitor the baby and document, and then the respiratory therapist. Again, we have our butterfly needle, a syringe, and then the stopcock. Now here they use a procedure using saline. They actually do it 2 ways. I've only worked with one other neonatologist that actually had the end of the butterfly submerged in water. The tip of the butterfly, it allows the air to escape but not get sucked back in. So here they're identifying landmarks. In this particular video, they are using the second intercostal space and the mid-clavicular line. I have also done it in the nipple line or 4th to 5th intercostal space, mid-axillary. And these babies are positioned with the affected side up to encourage the air to go up and the headbed elevated. So here they're showing the method with the tip in the sterile container and just pointing out the baby should be on monitoring, and the nurse will help support the baby. Babies over 28 weeks get chlorhexidine. If you're under 28 weeks, then betadine is used. Now here it mentions lidocaine. I have not used lidocaine. Usually the baby is pretty unstable and we just go ahead and evacuate that air. because once that air is removed, that lung can now have some space to reinflate. And this is just mentioning to make sure that the stopcock is open so the air has a way to get out. This slide is pointing out that you should talk to one another. People should be delegated jobs to do. Like I mentioned, this is the second intercostal space in the midclavicular line. And keep in mind, again, that I did increase the speed on this video. He's finding his landmarks. And then on the other end, if you are in the right place, you should see the bubbles escaping to show that the air is being evacuated. And you keep the needle there for a few minutes. You look at how much bubbling you have. If you have a lot of bubbling or continuous bubbling, that's a pretty good idea that your baby's probably going to need a chest tube. But if it bubbles a few times and then you keep watching it and it seems like all the air is gone, that it's not reaccumulating, maybe you have a good shot on the baby not needing a chest tube. And then what you would do is auscultate, listen to breath sounds again. Here they were repeating the trans illumination on the sides. And this just shows what it looked like before and after transillumination. Now here's the second way, using the syringe. The provider will put the needle in, but it's up to the nurse to be on the syringe side evacuating the air. The syringe back is pulled back in a slow and steady rate. And again, they're using the butterfly in the second intercostal space, mid-clavicular line, after it's clean. And you want to make sure that it is open so your syringe can pull back the air. Once your syringe is full, you need to close off to the butterfly needle, evacuate the air from your syringe, turn back the stopcock so you can now be in a position to pull back more air, and you keep pulling back on the syringe until you've removed all the air. So here they're showing you on the mannequin that the needle goes in and then they're pulling back slow and steady. Once that air comes in the right, that needle is in the right place, the syringe just moves back pretty easily. And once, see how we turned the stopcock and evacuated the air from the syringe? And now it is ready to remove more air. And then when the procedure is done, the needle should be removed and a Vaseline gauze covering the hole. Of course, you need to document the time. The provider will write a procedure note, but the nurse is also responsible for documenting the timeout, the start and stop of the procedure, and how the baby is doing. Now, sometimes if the provider has trouble finding that space, it can actually cause more injury. And you really need to be careful for the landmarks. And I think that's it for this slide. Now, if they are putting in a chest tube, you can see that the side is up. This would be the affected side, and the baby is supported by a blanket roll here so it doesn't roll back on their back. Someone needs to make sure that the arm doesn't fling back down, so someone needs to hold the infant's arm up. And the head of bed is elevated to help displace the air upward. As far as nursing interventions, you should know where your chest needling kits are or where the supplies are. If you are doing a chest tube, you should know the different types of chest tubes you have on your unit and where it can be found, and also locating and knowing how to prepare the Pleurovac system in which the chest tube will be connected to. During insertion, supporting the baby, trying to keep the baby as comfortable as possible, and always doing an ongoing assessment how the infant is tolerating it, and anything you can do to help support the baby and the provider. Okay, here is a pretty typical setup that a provider might do to set up their chest tube. This is the pigtail chest tube right here. And these additional things are what helps the provider insert that chest tube. And once the chest tube is placed, it is connected to this Pleurovac system right here. And you can see on this X-ray that this is a pretty perfect position for the chest tube to be in. After the chest tube is inserted, you want to make sure it's properly secured at the chest, and you want to assess the dressing. You want to make sure that you have a blue hemostat, that you have something to safely clamp the chest tube if something should happen. You can also keep a chest needling kit at the bedside as well in case the baby has another pneumothorax. You want to monitor for any collection that collects in the chamber. And you want to assess the water seal compartment and watch it for any bubbling or air evacuating. And also very important to evaluate your infant for pain and make sure that they are getting the appropriate medication for that. So now let's talk about something really important, and that is protecting babies' lungs. Okay, so BPD, or chronic lung disease, is injury to a developing lung. Babies aren't born with this. It's a result of damage to their lungs. Causes are multifactorial, and that includes a genetic predisposition, the baby's gestation, how long you're on and what type of respiratory support that you're needing. Some babies that are at increased risk to having a pro-inflammatory state, like intrauterine growth restriction or maternal choreo. Those babies are at higher risk. And just the baby needing respiratory support. We try to give it as little as possible, but we do have to give the baby what they need. We know there have been some things that helped, like antenatal glucocorticosteroids, as we talked earlier, that those lungs kind of speed up in maturity, and with this new approach to gentle ventilation techniques in early surfactant, they have helped us manage babies a little bit better, but overall the risk of BPD or chronic lung disease hasn't really decreased. But if we try to do our best in respiratory management, let's just try to do whatever we can to help these babies. These are some of the ways that we help babies assist their respiratory status. We have mechanical ventilation, and in that we have conventional ventilation or high frequency. We commonly use CPAP. And then there's also humidified nasal cannula or low flow nasal cannula. And I have this slide here just because I really want to stress how important it is that we take good care of our babies and really try our best to manage their respiratory status. Lung injury can result from alveolar capillary damage. And once that we have that capillary damage, fluid can leak into the alveolar space, and inflammatory mediators can be released. Maintaining PEEP, paying attention to weaning oxygen, and decreasing support whenever we can decrease it. Those are the things that we really need to be paying attention to and doing for these babies. This is a slide just showing the cascade of events that happen with lung damage. Mechanical ventilation really aggravates it. Even up to 3 to 5 ppv breaths can be enough to activate the inflammatory cascade. So alveolar macrophages and surrounding cells can release cytokines and oxygen radicals, and the cytokines can chemoattract neutrophils, which then migrate to the alveoli, which ends up damaging type 1 and type 2 pneumocytes, and atelectasis and inflammation results. Like I already mentioned, when there's capillary damage, you can see on the branch on the right, that ends up causing leakage and interferes with your ability to ventilate your baby, and then ultimately causing increased support. And online you can find several different versions of this illustration, but this I feel is a nice way to show the impact that inflammation has on these alveoli. On the left we can see everything's happy, going normally, and then on the right what happens when you're causing lung injury and the alveoli getting injured, and what happens with this inflammatory cascade being activated. When we talk about lung injury, we can talk about it in two different ways. When you talk about bronchopulmonary dysplasia, feel like that is an older term, and there's an old way to describe lung disease and a newer way to describe lung disease. 30 years ago when I started, we didn't have an appreciation for volutrauma and barotrauma, and we managed our ventilatory support quite differently, and that caused trauma to the alveoli. And with the old form of lung injury with bronchopulmonary dysplasia, it created larger alveoli and fewer alveoli, and ultimately resulting in decreased surface area. And they also refer to it as decreased septation or partitioning, which makes it harder to ventilate. And there is also a decrease in pulmonary microvascular development and increased pulmonary resistance. So the mechanics of the old form of lung disease, of bronchopulmonary dysplasia, was definitely a different type of injury to the lung versus this new injury that is being caused, which really is a reflection of an interruption of normal alveolar development. And it doesn't matter if they're just on CPAP, we are still, even though it's really minimal, we're still causing injury. We're still doing something to the alveoli that normally would not have been done to it, and that results in injury. This is just a diagram that shows the accumulation of responses to the result of evolving bronchopulmonary dysplasia, talking about inflammation, added insults like our respiratory support that we're giving babies, and maybe a genetic predisposition in developmental vulnerability. The smaller gestational age, the higher the risk of injury and chronic lung disease. So CPAP, we should all be familiar with it. That steady, small, constant pressure of air helping keeping our lungs inflated so babies don't need to work so hard to breathe. It prevents atelectasis, and there is an oscillatory effect and benefit from the bubbles doing bubble CPAP. So it is said that that oscillatory effect does have benefit. And because we do CPAP so much, it is super important to really give good care to the babies while they're on CPAP, monitoring their skin integrity from those prongs or that mask being on that nose, making sure they are bubbling well in the chest. The bubbling on the outside on the CPAP does not mean that you are getting adequate bubbling in your chest. The bubbling on the outside has no reflection on how well your baby is getting CPAP. Pick up your stethoscope and take a listen. Also, with that being said, keeping the PEEP is so imperative. Even removing the CPAP for a little while is enough time that atelectasis can occur, those alveoli can collapse, and then it's just going to take longer and potentially more pressure to pop open those alveoli back up. And when that happens, whenever you have to give that more pressure or force those alveoli back open, you increase that inflammatory effect and set off that cascade. It is important while you're doing cares, you have to do your assessment, sure, but when you take off that hat, someone should be holding that CPAP over that baby's nose, or however you're giving CPAP, maintain that CPAP as you're doing your assessment so your baby isn't de-recruiting alveoli in this process. Now, this is a video that is going to show you how much it takes and how fast the collapse happens. This is a rabbit lung. And you can see, look at, even after a few breaths, there's still collapse. There's still areas that haven't inflated. Still trying to recruit. And now, finally. And look how quickly the lung deflates. And then you have to start all over again, even though it was just inflated. So hopefully that is a little helpful. So just to mix it up a little bit, PEEP may cause A, low blood pressure, B, low lung volumes, C, pneumothorax, or D, A and C. And the answer to this would be A and C. And the reason why that is that yes, PEEP is good, but too much of a good thing is not always a good thing. Because sometimes if a baby is getting too much PEEP, it can actually overinflate them, overinflate the lungs, and compress upon the heart. Also, if we're giving too much PEEP, as we talked about previously, we can cause an air leak and cause a pneumothorax. So it really is that balance and is really that good assessment and nursing care. And being mindful to take away support when the baby is showing you that they can tolerate it. So again, with CPAP, skin assessment and maintaining skin integrity is imperative. The nose shouldn't have blanching. There shouldn't be any pressure on the septum. If you have the ability to alternate between mask and prongs, even if the baby doesn't tolerate being on the prongs, even if it's just a half hour, it will change the pressure points on that baby for even a short period of time is a benefit. Now I will just give you an example that at some point in one of the hospitals I worked at, the baby ended up getting some really bad breakdown on its nose. And even though we tried to continue to give the baby CPAP, because we could not maintain the CPAP because of that altered skin integrity, the baby ended up getting intubated. And then after the baby got intubated, several days later, the baby ended up getting a ventilator-associated pneumonia, and the baby ended up dying. And it just is that cascade of events that happen. And I'm not saying that's all it was. There were other factors with this baby, but that was one of the contributing factors that, gosh, if we could have just kept that CPAP going, would that have been enough? And did that pneumonia just perhaps put that baby just over the edge enough? So really what you do is so, so important. Now there are some babies that should not go on CPAP, and that would be a congenital diaphragmatic hernia where the intestine is up in the chest cavity. And if you put that baby on CPAP, that intestine is going to fill with air and occupy even more space in that lung cavity. And whatever lung is there is going to be affected. Babies with choanal atresia, well, CPAP will not work on those babies. And babies with significant apnea, CPAP doesn't do you any good if you're not taking breaths. So CPAP would not work for those babies. The circuit needs to be humidified and heated. We have a lot of water loss through our respiratory system. And typically the pressures are between 5 and 8. Now, another way we can support babies is through NIPPV. I think that it is used more now as we try to avoid putting babies on mechanical ventilation. And I think of it as CPAP with a rate. It gives an intermittent breath to help support that baby a little bit more. Now we could do another whole talk on mechanical ventilation alone. There's a lot of different components to mechanical ventilation. You have the PIP, or peak inspiratory pressure, and that is the highest pressure that is given to deliver the breath. PEEP is just like CPAP, that low residual pressure that helps keep the lungs inflated. Rate, or the rate at which you're giving breaths. And then volume-wise, if you are on pressure regulated volume control, you might set the baby's ventilator to deliver 4 mLs per kilo of volume. And another setting that can be manipulated is I time, or inspiratory time. And I time is shorter than expiratory time, typically 0.3 to 0.35. Mechanical ventilation can either be conventional ventilation or high frequency oscillatory ventilation. There are a couple more modes of mechanical ventilation, like jet ventilation. Jet vents are a whole different entity to manage, but primarily just conventional ventilation and high frequency are typically used. Here's just a comparison of the two main types of ventilation. On the left, you have just a conventional ventilator, and on the right is a picture of high frequency. And if you can look at the high frequency, one unique thing about high frequency is that in this area right here is a piston. High frequency is the only type of ventilator that is an active inspiratory and expiratory assistance in the baby's breath. And this is just a diagram of comparison of breath delivery between the two modes of ventilation. So here would be conventional ventilation, where there's a breath in and then a breath as the breath comes out. Whereas high frequency, if you've ever heard it, chug, 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 is these short breaths. And this just demonstrates on high frequency that there's active inspiration and expiration. So oxygen is also another one of those things that there is such a thing as too much of a good thing, and oxygen is definitely one of those. Oxygen is considered medication, and there are known side effects. If you have heard of Stevie Wonder, you know he's blind, but did you know it is related to ROP, where we did not understand that giving high concentration of oxygen was bad for baby's eyes, and that resulted in his blindness. Oxygen also forms free radicals, and free radicals cause damage to surrounding cells. They do that by cell membrane injury, enzyme inactivation, and structural protein damage to the cells. When you look at the lung related to free radical damage causes inflammation. As you've already seen, that's the last thing that we need. And free radical diseases that result from this injury is hypoxia perfusion injury, BPD, NEC, ROP, HIE. These are all contributed by free radicals. Free radicals can also impair surfactant synthesis, and we talked about how important surfactant is, so that is nothing we need to be interfered with. It also depletes antioxidants because antioxidants do try to combat free radical damage. Free radical damage also inhibits lung growth, and again, just causes profuse inflammatory activity in the lung. And speaking of oxygen, we need to be monitoring our oxygen saturations. And I really just want to point out then that when you put your pulse ox on, the sensor or the light detector needs to be directly across from the other side. You can't have one over here and then one over here. In order for it to pick up accurately, they need to be across from one another. And I know that seems simple, but there have been enough times that I've seen it misplaced. Just know that phototherapy can affect your pulse ox reading, so you might have to cover it with a little towel or something like that. And just a few closing things as we end the talk here, uh, just to help us just be a little mindful, especially with babies that are needing ventilatory support. They can have a lot of things going on. This baby looks unsupported, a lot of wires everywhere. Sometimes we can't help it. This baby's restrained. We need to be asking ourselves, what can we do to make this scene a little bit better, and looking at things in the eyes of our parents. In contrast to this baby, still on respiratory support, but is contained in boundaries, and the bed is pretty clear. Probably not as much going on with this baby as in the previous slide, but just try to take those moments to make things a little bit better for your patients. When it comes to x-rays, please take those extra few minutes to move wires. They can be very distracting and can cover something that is kind of important. So please take that time to put the leads on the side or take them off completely if it won't injure their skin. Make sure your baby is positioned flat. I will say for these x-rays, the clavicles look pretty equal, which means that the baby is pretty flat and not really rotated. So it is really helpful when you can take the time to do that, also making sure that your head of the bed is flat. Along with the highlighted YouTube videos and different slides. These are some references that I did use to pull my presentation together. So I think that's all I have for you guys. I hope you found it worth your time. If anybody wants another talk on something, please tell Lynn or message me, and I will be happy to do that for you guys. Thanks so much.